Hello and welcome. My name is Dr. Raj Persaud. I'm a consultant doctor and psychiatrist. I work in Harley Street, London. And I'm delighted to be joined today by Gert. Now, Gert, you're going to have to help us because I always get the surname wrong. Jan van Rensburg, I think is roughly speaking how you pronounce that. Is that right?
That'll do fine. Thank you very much. It's Janse van Rensburg, but that's fine.
Okay, you said it much more exotically and interestingly than I did. So welcome to the program. I see you've got some people working behind you. That's very exciting. It looks like BBC News, but as long as those people know not to say anything and not
they're going to be very quiet.
Okay, good. That's cool. I'm very impressed. You have a large staff. That sets the right psychological impression straight away. Much better than me. All I've got is a picture of Anna Kournikova in the background playing tennis. Anyway, welcome, Gert. You have a very interesting story to tell us about a particular kind of therapy that you do. But before we get into that, you're a therapist. You work at White River Manor, a well-known clinic in South Africa. We've talked a bit about that clinic already on the program a few times, so we'll talk a bit more about it. But before we get into the kind of therapy that you do, Gert, and some of your thoughts about therapy and the kind of patients you treat, tell us a bit about yourself. Tell us a bit about your journey to become a therapist. Were you born always wanting to be a therapist, or what happened? Tell us a bit about your journey to becoming a therapist.
No, my journey took a few interesting curves along the way. I was born with a congenital heart disease, which meant that I had open heart surgery at the age of 6 weeks, and then again at 3.5 years. So
right. Wow.
I grew up, very, very much grew up with a narrative that one day I'm going to be a doctor.
Oh, okay.
So when the time came, I duly applied to medicine school and was granted entry. And during the course of the first year of my studies, I realized, and obviously getting a little bit more emotionally intelligent, and at that stage of your life, around 18, 19, you start realizing that perhaps this narrative is not necessarily the one that you want to follow. So I ended up at the end of my first year, having passed my first year medicine, walking across campus and deciding, this is not what I'm going to do. So I knew that I could go home and say to my parents that it's fine, I'm not going to study medicine, but there shouldn't be too long a pause between that sentence and the follow-up.
I agree. Being a parent myself, that pause is an eternity, a geological age.
Exactly.
Anyway, go on.
Exactly. So I knew that they wouldn't mind too much, and just so long as I had a different plan. So I walked into the humanities building, not having heard anything about psychology ever in my life. Looked up and down the list of departments, looked at psychology, think, well, that's kind of like somewhere close to medicine, and promptly went up and I think we haven't. Are we back?
Yes, you froze a little bit there. Anyway, you were saying you went to the humanities department and you chose psychology. Yes. Could you say a bit more about that? Yeah, interesting.
And I chose psychology, not knowing too much about it. But what also enticed me was that I had a number of credits that I could carry over from my first year. And that set me on my road. And from there, I did a bachelor's degree with psychology as a major. In South Africa, you need to do an honors degree and then a 2-year internship to qualify for your master's, which then allows you to register with the Health Professions Council. And then I qualified as a clinical psychologist.
Did you enter psychology always knowing you wanted to be a therapist? Because obviously there are lots of different branches of psychology, like educational psychology, occupational psychology. Did you know, because like the fact you went to medical school, that you always wanted to treat patients? Oh, I think we might have lost Gert again in terms of the internet connection. Oh, there we go. It's back. Yeah, go on.
We're back. Yeah. So that set me on my path as a clinical psychologist. After I qualified, I started working at a facility just between two of the big cities in South. I started working at
Okay, you're back.
Are you there? Can you hear me?
Yeah. I don't know. Is there anything
Okay.
we can do about the
Okay.
internet connection? Because it keeps coming and going. I mean, you're okay now, but is there anything we can do about it, or there's nothing we can do about it?
Yeah. Not that I can do at this stage. Let me ask
Okay.
one of my colleagues. Can somebody just call for me, just to see if we can do something about the connection? Thank you.
Yeah, because it keeps
Okay.
coming and going.
So we continue.
It's okay now. Yeah, sure. Go on. Yeah.
Yeah. Okay. So
Right. So I was asking
I started my career at a facility just up.
Yeah, go on.
Mm-hmm. Go ahead.
Well, I was asking you about.
I started my career at.
No, you go ahead. You go ahead.
Okay. Right. So I started my career at a facility, a rehabilitation facility. Also, not again sure that I particularly wanted to be in the field, but I enjoyed it very much. Learned a lot about the clients, which are generally very intelligent, very rewarding to work with if there's a willingness to change. And my career path took me from there eventually to private independent practice. That was followed by a 7-year stint in the UK, where I worked in Birmingham, dual diagnosis as well as with addiction, and then back to South Africa.
Okay, now this is very interesting because I worked in America for a while. Do you think there was a big difference, and did you learn a lot by traveling to another country and practicing clinical psychology in another country? Were the patients very different?
Very much so. It was a huge learning curve. I benefited a great deal. A lot of the courses that I was able to attend wouldn't have been able if I had stayed in South Africa. I met a wider range of professionals that I collaborated with. Later in also writing a chapter in a book about psychological therapies for hard to reach client populations. And I would have never have had those experiences had I stayed in South Africa.
Ah, you mentioned hard to reach client populations. Tell us a bit about that, because that's the big conundrum at the heart of the field, isn't it? Tell us a bit more about that and your thoughts about that.
Yeah, so as it's known in the UK, severe and enduring mental illness, so people that suffer from ongoing episodes of psychosis, hard to treat psychosis, bipolar disorders, those kind of things, also comorbidity features in that group. And I had the privilege of working in the Birmingham area with a number of leading specialists, Alan Meaden, Dave Hacker, those kind of guys that we did a lot of interesting work in terms of shared formulations, in terms of arriving at new innovative interventions, from early intervention through to residential treatment for people that have been in the system for a long time.
So could you say something about how you reach people who are difficult to reach, and what makes many patients or some patients difficult to reach?
So I think some of the most common reasons for that would be treatment-resistant episodes of mental illness, where people don't respond to the normal pharmacological interventions, and then one is left with the talking therapies. And one of the interesting opportunities that I had was to learn from the Finnish project in Turku called Open Dialogue, which is was developed by Professor Jaakko Seikkula and others, and followed a system where the client is treated within the community that they find themselves. There's an open dialogue, as it's known, between various members, right through from a possible employer to family members. Those kind of open dialogue meetings only happen in the presence of client. There's no multidisciplinary meetings where the client isn't present. And the client, even in the midst of his psychosis, plus the voice of the psychosis, for instance, is given an equal standing within such open dialogue meetings. It reduces anxiety for the client. It validates the experience for them without feeding into the experience or strengthening the beliefs. And in that way, the intervention becomes much more acceptable and the person becomes more accessible, which in the end, over the course of a number of months or so, has a very positive outcome.
So you're talking about psychotic patients. Patients are hearing voices. Could you say, maybe give us some examples of some experiences you had with really very ill people and how this works? Because I imagine it takes a lot of skill to sit in a room with someone who's really rather ill and not do something to do with treatment, because we're very, very driven to try and treat it, aren't we?
Yeah. No, most definitely, it is quite difficult. Obviously, in a most acute phase, it most likely will not be the first port of calls. There is a measure of pharmacological intervention, mostly in the form of an anxiolytic, just to get the client in a safer space. But obviously, clients would also need to be in such a state of mind that they would be able to participate in a meaningful way.
Oh, so they can't be too ill, is what you're kind of saying. Is that right?
That's correct. If they, although the Finnish model, if you do some reading, the Finnish model does take people in right through from the very first presentation often, but they also try and minimize hospitalizations and medical intervention. But so that doesn't rule it out necessarily.
This is very interesting, because there's a theory that the medicalization of mental health problems, i.e. giving people a diagnosis and treating them with medication, is kind of a way of separating them from the rest of us. I think the Finnish model is saying we need to see mental illness as not something that you run away from, but you kind of embrace, if you see what I mean. Is that right? Because in the third world or the fourth world, or whatever the term is now, where there's no treatment, there's no hospitals, there are no therapists, what happens is the family and the community and the village rally round, don't they? And they kind of help look after the person. And we've taken a very different model in the West, which is you've got a disease and you need treatment and you need to be removed from the community. What are your thoughts about that? Have I captured that correctly?
I think that's very accurate, correct, yes. And I think it does bring that separation, and it brings a stigmatization to the table as well, that then the person becomes the diagnosis. I know Professor Tom Anderson from also from one of the Scandinavian countries. He had a line that he shared with me at some stage during a training course down at Tavistock. And he said one thing that he always asked. Okay, we're back. Something that Prof. Anderson always asked his psychotic clients was, what part of you was not addressed? What part of you was not attended to? And then the answer most often given was the psychotic part of me. So everything around is addressed, but apart from that is the unspoken. And it seems that by confronting that, addressing that, it reduces anxiety, it makes it more accessible. It does not feed into the psychotic phenomena, but you share with a person, for instance, that I know that with sleep deprivation, or if I'm lost in the desert somewhere without water, that I too will have hallucinations. If I lose someone dear to me, I can walk down the mall in the shopping center and I can imagine that I'm seeing that person at the other side of the mall. And then it's maybe just somebody with the same hair color or the same style of dress. But in that brief moment, I convince myself that I'm seeing my loved one pass.
So some people would say that's an attempt to almost normalize the symptoms. Is that right?
I wouldn't go so far as to say it's normalized, but it gives it a sense of validation instead of making it or defining it into something that is only problematic or only something that is going to be that has to be left unspoken about.
So, at the risk of being provocative and somewhat challenging, you see, what's really interesting about this, because it's a very common idea now in psychiatry, and it's often called critical psychiatry, for example, and it was embraced in a way by what was referred to as the anti-psychiatrists in the 60s and the 70s. People like Thomas Szasz and Ronnie Lang would be famous examples. If you had cancer or a pneumonia, we wouldn't go around trying to embrace it. We wouldn't go about trying to normalize it or say something like, I've been quite breathless at times when I go for a run. What we do is we'd hurl an antibiotic at that and try to treat the thing and get rid of it. In other words, it's seen as something to be dealt with, something bad, and something to be surgically excised. So I would say that one of the reasons why, I know I'm being provocative and challenging here, that psychiatry goes down the route of embracing it is because the treatments aren't effective enough to excise the thing. And that's why we end up embracing it. Well, that's not necessarily sensible. Anyway, over to you.
Sorry, Raj, I lost you there for a moment. Can you just recap for me?
So in the rest of medicine, if you had a raging pneumonia or a cancer or something like that, we would throw treatment at getting rid of the thing, right? We're not getting rid of the thing here in psychiatry because maybe our treatments aren't as effective, but it doesn't mean you'd want to embrace it because it's still dysfunctional. So that's the medical model view, which is don't embrace it because something's not working right. Anyway, over to you. What are your thoughts?
I think the approach is more one of not just focusing on the symptoms, but focusing on the person as a total being, of which that has become a very entrenched sometimes part of them that they somehow need to find a way to live with. We might not be able to make it go away, but we can improve the manageability for the person by finding a way of somehow acknowledging that it's there, without validating the symptom, but validating the person is the way that I would put it.
Yeah. Okay. All right. Now, you've been on a journey, and you were now a psychologist and a therapist. You've ended up becoming what's called an equine therapist. Is that right? Tell us a bit about what that is and how you ended up doing that.
Okay. So I've always had a love for horses. I've owned some horses in the past, done some just general outrides for myself and my son and so on. And in 2016, I worked at a facility in our province of KwaZulu-Natal at the foot of the Drakensberg Mountains, where you go up into Lesotho, a beautiful part of the country. And I had the opportunity to incorporate equine therapy, equine-assisted psychotherapy with my standard practice there. I did a course known as the EGALA model, Equine Assisted Growth and Learning Association, which was established in the United States. It was also present in the UK and quite a number of countries around the world. I did a course in that and then started incorporating that as part of my standard practice, both individual as well as group therapy sessions. So the equine therapy is interesting because it is based on metaphorical and experiential learning. So you would, if you could imagine that if you come to a consult with a psychologist like me, then we sit in the office and we operate mostly in the cognitive space. We use talking therapies, and that's good. It's evidence-based, it's well proven, well researched, but at the same time, we make use of words and we stay in that cognitive space. If we're lucky, we can incorporate some of the emotions and you can get to some deeper meaning or understanding. But people staying in that cognitive space, it's good that we do that, but it's also where all our fears are, where all our phobias are. And we need to somehow use different tools to access the other parts of us. And we do that through music therapy. We do that through art, through different means. And equine therapy is exactly the same. So basically, we take the problem out of the cognitive space and we put it in the space where the horses are. It's all ground-based work. There's no riding in this particular model. And we invite the person to experience, and we invite the person to create a story, to create a metaphor for what they see. Now, it's very interesting because horses are social animals like we are. They experience different sensations, or we would call them emotions. They are herd animals, so they have relationships within the herd. And we often see some of the difficulties that we have reflected in their behavior, and that helps us to construct the metaphor then. So the person can then go, instead of, this is how I think about the problem, they can go, oh, that's what the problem looks like. And by externalizing the problem, it becomes less threatening, perhaps, and also much more workable.
Okay, so tell us practically what happens in a session. The patient arrives and you take them to a place or a stable where there's a horse roaming in the field or in a stable, or there's more than one horse. What practically happens?
Okay. So ideally what you want is a small herd of horses, but if you have one horse, you have one horse. But generally they would need to be in a paddock, in a natural environment. In the Northern Hemisphere in the winter months, that's not always possible. So it happens in a barn. But that also works. The more natural it is, the better, because then it elicits the horse's natural behavior, and people can use that as a mirror. We'd have a small introduction, explain the model to the client in the basic way that I've explained it to you now, and then perhaps do a bit of a mindfulness exercise just to ground them and get them to calm down. And then invite them to take a walk through the paddock and see what they observe in the storybook, and name the elements, what they see. You would have an idea of the referral of the client, or maybe if the client is an inpatient, already have some idea of what challenges they do face, and you ask them which of those challenges would they choose to engage with today, and then to develop a story and start weaving the facts or what the observations into that.
So let's say the client, because I did one of these sessions. I made a BBC Radio 4 program a long time ago about equine therapy. So I was plunged in as a client, as it were, while we recorded the program. So I went over and just was left to my own devices, just as you described. At first in the field, and there were several horses there. I went over straight away, and maybe it suggests I'm a gregarious, sociable chap, and to try to connect with the horses and pat them and talk to them, etc., etc. They ignored me, which I found a bit disconcerting. But the therapist spent quite a lot of time, I think, interpreting that, which I thought was a little bit over the top. But anyway, so what are the different things you observe? How do different patients react to the horses? What happens in a wide variety of different circumstances? Give us some examples.
So what happened once with me, which gave me a huge fright, was I did my little introduction in a group therapy setting, and as I invited the clients to step into the arena, the one lady stood up, promptly threw her arms in the air, and started hyperventilating, falling over backwards. I had no idea what was happening to her. Rushed somebody off to get the nurses and the emergency pack and whatever. I was afraid she was having a cardiac arrest or something, but she was going into a full-blown panic attack. What she hadn't divulged to me previously was that she had a bad encounter with the horse, and therefore she panicked, but she never divulged that, which is also interesting in itself. So you could have anything from that to other incidences where people really connect with the story. They create a good metaphor. They identify some of their own behaviors or people close to their behaviors in the horse, or sometimes just in the area around them, and it helps them to formulate a visualization of their challenge. I can tell you a very interesting story that happened with one of my clients. The gentleman arrived at the clinic after having been through some trauma in his life, and he had previously had some physical reasons why his mobility was compromised. He still held on to those kind of beliefs that his mobility was compromised, although the medical staff reassured him, all the various specialists, there was no reason for him not to be able to mobilize. I was very cautious about taking him into the paddock because of this reason. And horses are fright animals. They sometimes move very quickly, very fast. And if you have somebody with restricted mobility, that could pose a risk. Anyway, he convinced me to do that. I took him down, and the one horse behaved in the most remarkable way. She came up to him where he sat in his wheelchair, and she lifted her foot, her 1 foot leg, and she put it on his lap. And I was a little bit worried because I'd never seen the horse do this before. I don't know what she was going to do, if she was going to paw him or whatever's going to happen. He just looked at this animal towering over him, and then he slowly took hold of her leg, and he held onto that, which to me felt like ages, but it was only a few seconds. The horse moved away. She came back. She did it again. This guy became quite emotional. I asked him, "So what happened? What just happened here?" And he said, his words were something to the effect, "She was giving me a leg." And then a lot of anger came out, which was directed as me as the therapist, not wanting to take him down to the paddock in the first place. However, there was a lot of anger towards other elements of his life. So that anger had to surface at some stage. And a number of weeks later, when he left, he walked out instead of making use of he broke through those beliefs, which for me is one of them. The beliefs that his mobility will always be compromised.
Okay.
There's a meaning sometimes in the sense for the client that is difficult for the observer just to. You have to be present to see the emotions and see the whole transaction between horse and animal. I mean, it was Winston Churchill that said made the famous quote that there's something about the outside of a horse that speaks to the inside of man. And
wow!
I firmly believe that.
Yeah.
So
yeah. Can you say a bit more about that? Why do you believe that?
Well, from a personal experience, my own connection with animals in general, but specifically with horses, I found them to be very intelligent animals. I found them to be very caring and compassionate towards some of their own species, and I've seen to people that have various fears or handicaps also. Somehow the horse can sense that. I don't know why. But they do in some way sense that this person is vulnerable, and they can be very gentle in showing acceptance and interest and care. And I think our very long history with horses, if you think about it, it's probably the animal that we've domesticated for a very long time. I don't know if it's the longest, but it's the animal that we've definitely had the most use of. There's another interesting quote that says that every step man's taken from coming from barbarism to a modern man has been either on the back or alongside a horse. We hunted them, we eat them, we still do. We clothe ourselves in them, we ride them into battle, they work for us. We still refer to our vehicles as having so much brute horsepower. There's a lot of equine sports. And we, in most recent decades, started using them for therapy as well. So I don't know of another animal that we have so many uses for and such a connection with as human beings.
Okay, so I've heard of equine therapy. Why have I not heard of other pets or other animals being used in a similar way? Why is it horses in particular seem to lend themselves to therapy? Unless I've got that wrong, and lots of other animals are used as well. But I've definitely heard of equine therapy. I've not really heard of other animals being used in a similar way.
Yeah, I think other animals are mostly used as companions in terms of people that suffer from loneliness or isolation also. Mostly dogs, definitely, the little bit that I know about that. But I think it's for those reasons that there's similarities between us and the equines in terms of them being social animals like ourselves, that they form little family groups or herds, the same as that we do. They have very strong individual characteristics that there's a hierarchy. More dominant animals like more dominant people, subservient animals that are quite feisty, and others that have a very, very placid nature. And I think all of those features speak to us as humans a lot more than we would not necessarily recognize in other species.
What kind of patient do you think of using or referring or recommending equine therapy to?
So what we do here at White River Manor is that all the clients have the opportunity to engage with equine therapy. Some of them are a little hesitant at first, but we ask that they take a bit of a chance and go for at least one session. If they don't feel comfortable, then we would insert something else in their program that they would also benefit from. So there's a wide range of clients with wellness profiles, clients that have come in that are exhausted, suffer from burnout, clients that have various diagnoses from generalized anxiety disorder through the mood spectrum disorders, and then also with substance dependency. So I wouldn't say that there's particular clients that are more suitable. It depends rather on the personality and the willingness for the person to enter that metaphorical and experiential learning space, and how much they can identify with that, whether they would be willing to take that risk, so to speak.
You mentioned that when this patient who had the horse put their leg on their lap and it was linked to their own mobility problems. You mentioned that they kind of came into the paddock, but you're not. What I'm getting at is that you don't seem to be doing the thing that most people would have thought you'd be doing with horses, which is getting the client to ride them, if you see what I mean. So why is that? What's going on? It's like a one-on-one engagement, which is not riding the horse. So what's going on there? Why is that the case?
We have another lapse in contact. Sorry, we had another lapse in contact there.
Oh, I see. Sorry. Why is it that the client kind of engages with the horses on a kind of one-on-one basis and the client doesn't ride the horse, if you see what I mean? It sounds like the client stands next to the horse and deals with it that way. Why is, because it seems to me natural for many people to think I should be riding this horse. I'm not saying it's appropriate, but I'm just wondering what's going on there. Why are you taking that approach?
Yeah. So in the model, we treat the horses almost as a co-therapist. So they have to have a certain standing within the session. The moment that we start putting head collars on, that we get on their backs, fully tacked up, we start being in control of the animal. So then we bend the animal to our will by doing that. What we want is for the animal to be as natural in their own environment as possible, and just display natural behavior, so that we don't force something on them, but that we can observe their behaviors and then have that experience and create the storyline.
Okay. Now, you also mentioned being a bit anxious when the horse approached that client, that something was going to happen. I'm a little bit surprised you're not more anxious, to be honest, because animals can be unpredictable. Is that these are very well-trained animals? I mean, surely from time to time something's gone a bit wrong. I mean, horses can be startled and they can kick and stuff, right? So,
so you
never
have to
make never happened.
Fortunately, a client has never been kicked, but the horses are habituated. They're not particularly trained in any particular discipline or so. But they have to be very used to having people around them. So you have to also select the horses in a way that you're not going to have a horse that is totally green or being around people. You have to have horses habituated. Things have happened. Horses don't have a particular good sense of where they put their hooves, and they don't watch out for that. So when the horse moves, you need to keep your toes out of the way. Once or twice people have been bumped by the horse, but not intentionally as to hurt them. That fortunately has never happened. So you have to have horses where people can move behind them, touch them on various parts of their bodies also without necessarily becoming startled or show too much of a wild reaction to that. Yes.
Okay. Now, has it ever gone, sorry to ask you a very, very difficult question here. Has it ever gone badly wrong? I mean, all therapy has a risk. Some therapy works, sometimes it doesn't work. Sometimes it can go catastrophically wrong and people can get worse because of therapy. Not necessarily the fault of the therapist, but has it ever gone wrong, in your opinion?
Wrong in the sense that that the model is just not adapt to, or the person doesn't adapt to the model. It's not something they really like things much more clearly defined. The openness of the model, inviting them to create a story for themselves, to share their observations. I've had clients that said, "No, I'm sorry, this is not for me. This is all too much up in the air. I really don't connect with it. It doesn't. It's horses in a field. What do you want me to say?" So,
yeah, that's a great line. Anyway, go on.
Yeah. There's a brown horse, there's a grey horse, and there's a darker bay. And what do you want me to say? So I've had that, and then you have to be creative very quickly and say, you know what, let's maybe insert something else in your program. You have to treat the clients with respect as well. People inherently know what perhaps is going to work for them, and we have a very short space of time to use interventions that are going to hopefully bring some meaning and make some change. And if it's not going to work, we're not going to force it on them.
But that was very telling, that example. If the client says, what do you want me to say? I see 3 horses in the field, and that's telling us quite a lot about that client, isn't it? I mean, they've got in my opinion, I mean, you're the expert here, they've got a slight lack of imagination, and also they're not willing to punt, take a risk, and also they're not willing to engage where they're not certain what's meant to happen. They need to be led by the hand. They need instructions, right? And you're creating a free form situation, and they're not reacting well to that. And I think there's something really interesting about improvisation, because I think a lot of life is an improvisation, and I think a lot of people just can't cope with that. And yet, a large part of what it is that helps people get better is the idea we're going to have to improvise. Again, what are your thoughts?
I agree with you. That is exactly some of the thoughts that will go through my mind as well. And you do in that situation engage with the person and offer suggestions along some of those lines. That this is a very unstructured situation for you. You don't really feel in control. It's not predictable. What happens on the outside in your life when these kind of things? How do you deal with situations like that? So, and sometimes that does have a positive effect, and it starts off the conversation in a direction, because people bring their own narratives in and project that into the situation. So sometimes you can still make something of it, but then there's a little bit of perhaps what I'll call a bit of pre-therapy before you then try and engage with the horses again. Sometimes people are quite surprised, but I've had a few clients that have politely declined, and then we follow the more talking therapy route.
But White River Manor is interesting, and the equine therapy is offered. First of all, it's not offered in many places, but it also seems offered in a sense that people almost are encouraged to think of it as a deeply essential part of the program. It's not an add-on. It's not like an optional extra. No. That's very unusual, isn't it, for clinics? So tell us a bit about that.
I think it is fairly unusual in my experience. In other clinics, I know that there's equine therapy adjacent to the clinic or available in the area, and people can go and investigate or take that up, perhaps on recommendation. But here we've made the decision to make it an integral part of the program. I started the equine therapy at the manor when I joined in February last year. I brought the horses with me, so it was really my passion to continue with that. We've had some really favorable responses from clients and good feedback, to the point where we have now appointed a sole equine therapist that does that full time, so I can concentrate more on the clinical psychology part, my major role. But I'm still involved with equine therapy and will be in the future. But yes, it is an integral part because of the feedback and the response from the majority of the clients.
Again, I'm going to ask them some somewhat naive questions. How come White River Manor had horses in the first place? I mean, one of the reasons why this is going to be a rare thing to offer, you've got to have the facilities of stables and lots of land, and the horses have to be looked after. So it's almost like, was it an accident? The clinic was next to a stable, or what happened there? How come you guys have horses? Because that's a hell of a thing.
No, the clinic is in a very fortunate position to be in a beautiful part of the country, with sufficient land available right on the premises and adjacent to it to allow for paddocks, evening paddocks with shelter for the horses, as well as daytime paddocks. And then so there's enough ground, and there was good insight from the clinic side to allow the suggestion to take place. I know that it's previously investigated, but it wasn't possible at that stage. But since last year, February, it has become possible to include that. So It was a conscious decision.
Yeah. Okay. I get the feeling that this is a great idea for certain kinds of people. I wonder if it's people who've had a very traumatic, deep childhood experience. They're wounded in some way, and they're finding it difficult to verbalize the thing. I'm thinking the kind of client it wouldn't be that helpful for someone's got a very specific problem, like they say, I just drink too much at parties. I'm functional in every other way. I don't drink normally, but if I go to a party and as people start drinking and I start drinking, I get way out of control, and twice a month it ends really badly. I just get the feeling that someone with that specific a problem, who with the rest of their life is together, wouldn't be the kind of candidate that would benefit. I don't know if I've got that wrong. What are your thoughts?
No, I wouldn't say that that's wrong, but I've seen clients on both sides of the spectrum benefit. Even a person that comes in with a relatively simple narrative of I've fallen into addiction because of a long-standing habit, migrated from social experimental to abusive patterns, and just now can't let go of it. And then sometimes they are also able to identify some of the observations as relevant. Often to do with setting boundaries is a theme that often comes up when they notice the behaviors of the horses and the paddock that they find them in. The theme of setting boundaries comes up, and which is something that they need to do when they want to let go of alcohol, let going of changing people, places, and playthings. And you can ask them to construct little exercises of how are you going to move the horse from one end to the paddock, from one end of the paddock to the other side, without forcing the horse, without controlling the horse. How do you motivate that kind of movement from point A to point B, representing how are you going to move yourself from one end of the spectrum to the other, solely by motivation, not being forced into moving. So there's various little metaphors that you can assist the client with, and convert that into exercises that they can relate to.
Yes, I'm really impressed. You're really good at this. So, isn't there another dimension here, which is that we know that there was a very big trend in the 50s and 60s to say that kids who were cruel to animals were going to grow up to be serial killers or psychopaths. But there's something about animals' vulnerability, because they can't defend themselves in the way that humans can, and they aren't laws that, although there are laws that govern cruelty to animals in quite the same way as it applies to humans. So, is there something about the vulnerability of animals that is important, do you think, in the therapy?
I think there is, yes, definitely. Although with horses, if you are going to be disrespectful towards them in some way, they likely will react, either by vacating the space, or maybe showing their tail in. So
you don't want to mess with the horse, basically. There's no point being cruel to a horse. You'll get a reaction.
No, I don't think so. I don't think so. Yeah.
Right. Okay.
I had a small little anecdote that I can tell you. I'd once had a client with a particularly spiteful streak in his interactional personal style, and he would goad, or he would prompt people into reacting, and then he would stand back and say, "Oh, but what's wrong? What have I done? I haven't done anything." So how this played out in the arena was the one horse had a small little nick that she obtained somehow, as they do, and I could see that it drew his attention, and the next moment he kind of just poked his finger at this small little wound, and the horse immediately reacted, and he then pretended as if nothing happened, and I thought, okay, the horse will take care of this, and he wasn't certain whether I had seen him. And I just asked what happened, and he said no, he doesn't know, nothing. Nothing happened. He doesn't know. And the next moment, a few moments later, he did it again, but with a little bit more force. And that was the only time that one of my horses actually showed a client some teeth, with the intent of really giving him a nip. He had such a fright that he stumbled backwards. And then the other clients at that stage noticed. Sorry, I just lost the earpod there. Okay. The other clients noticed what happened. The other clients noticed what happened, and that gave rise to a really good discussion about his role and the dynamics within the group, and that he does that exactly, and then he wants to plead innocence or take the victim role, because he was quite upset. Oh, the horse tried to bite him. No, the horse didn't try to bite him. The horse was the horse was defending itself. You're the cause of this, so you need to take responsibility. So it turned into a good dynamic discussion.
Yeah. Wow. Have you got any other examples like that? That's very interesting. I mean, that's quite hardcore, though, quite disturbing. But anyway, any other examples like that?
I can't think of any right now at the moment. Not in that line.
But where a horse reacted to someone, goading them. That's really interesting.
Yeah. Perhaps not in that sense, but I have seen where horses have shown what we in human terms would call compassion. Maybe they would just, the horse was just interested, coming up to the person, nuzzling them, especially when and that seems to happen quite often when they have challenges around loss or coming to terms. Or
yeah, I'm still here.
Needed to deal with loss. And then what happens is that they interpret the story that the metaphor that they construct, the story that they tell is that the horse is showing them care, the horse is showing interest. It's helping them to overcome, they don't feel that loneliness anymore. So there's been quite a lot of, that happens fairly often. That the care that the horses show.
Yeah. On horses, interesting, because you mentioned how closely they have lived with human beings and what an important role they've played in the lives of human beings from the time before we had machinery. And I think in Jared, I think his name is Diamond's book about development, he said societies that had the horse and could train the horse were given a huge advantage over societies that didn't, in terms of answering the question why some cultures have developed like in Western Europe and become advanced, and others have, in other parts of the world haven't developed at quite the same rate. And having access to horses seems to have been quite an important aspect of that.
That would make sense.
Yeah, interesting, I think. But do you think that our long history and the kind of people don't necessarily feel an affection for horses? People vary in their affection for animals. Some people are indifferent to animals, but there's a sense in which even if you're indifferent to animals, you treat horses with a great deal of respect because they're really big and they're quite powerful. And there's something kind of majestic and they're always put you in a bit of awe. They're the only big animal really that you get close to in most modern societies. So is there something about that history that you think might be important in the whole therapy element?
I think so. That's not necessarily something that we would overtly discuss in the therapy, but I think people's experience of that, as you described it, it is there in their subconscious or their conscious mind that they have some association. They walk over a square somewhere in a city and there's a famous general or somebody on the back of a horse. They're familiar with those kind of scenes. I don't think it's many people would be unfamiliar with the various equestrian sports that's available, from show jumping to racing and those kind of things. So I think it has very much a presence within our minds, whether we directly associated with them ever in our lives or not.
So coming at this from an angle which may be correct or incorrect, I don't know, but one of the things is you put people in a situation they're not used to when you present them with a field of horses and just leave them to it, and you don't give any directions, right? So one of the things that it seems to me that immediately is tested is their ability to engage with the world in general, because this is a question: am I going to engage with this thing, or am I going to walk away and complain, right? And I think this engagement point is really crucial in psychiatric disorder and in addictions in particular. I think it's people who can't engage with the world in a functional way that turn to addictions as a form of disengagement. But again, what are your thoughts about that?
I agree. I think it's a model that lends it well to make that evident to them, and that level of disengagement that they often bring as part of the problem, that they find the substance allows them to engage, or the substance has become a substitute or a companion in that way that they can manage themselves. I think it does resonate very well with the model.
Do people ever complain that it seems a bit hippie-like? I mean, equine therapy, to people who don't know anything about the field, think, oh my God, this is like a fringe thing, a crazy idea, these crazy therapists, because psychiatrists and psychologists have a reputation of being a bit crazy. Do you ever get that reaction that this is just crazy and a step too far? And it creates a negative impression of the clinic in the eyes of some people who think you're a bit of a hippie and slightly crazy.
I think what I've most often heard as a thing is, oh, I don't know if I would like to do that. That sounds a bit airy-fairy for me. So we've heard those kind of comments in therapeutic orientation, but the client would sometimes then mention that amongst the other clients, and then because people come in different stages of their therapy, there's at least always one or two, three that had a very good experience, and then quickly dissuade them from that ideas that they have. So amongst the client population themselves, they speak of it with positive terms.
So you said you have your own horses, is that right?
I do, yes. The horses at the clinic at the moment came with me when I joined the team.
Ah, you brought your horses with you then?
I did, yes.
Okay. Are those the only horses the clinic has then? Yours?
At this point, the three that's here at the moment is a small little herd that we have that we use, which is more than sufficient. Yes.
Okay, so horses require looking after. They require feeding. I think they require cleaning. I don't know much about horses, but there's a kind of looking after bit, which is why I know some people who are stable hands. It's like a full-time job. So is that part of the therapy? Can the patients volunteer for that bit as well?
The clients at the manor know if they do want to engage with the horses by brushing them at some stage, or taking some apples or carrots or whatever, or just want to see how they are fed, they are more than welcome to join myself and some of the assistants that we do have, that they can participate in such activity. But no, it's not required, and it's not something that we allow them to do on a regular basis by themselves. No.
Okay,
obviously, and do you go for safety reasons?
Do you go riding on the horses yourself? Do you enjoy horses in that way? You like to go riding?
I do, yes. Very infrequently with these, but I do go riding in other circumstances, yes.
Can I ask what other circumstances?
Just for outrides, there's some really good areas in this part of the country, out towards Kaapse-Hoop, which is a small little town about 40 kilometers from here. It's quite well known. There's still some wild horses in the area. It's one of two areas in the country in South Africa where there are wild horses that are protected and left to roam. They're not quite certain where the origins of those wild horses, but they in the area there's a stable that allows you to go for outrides. And we also make that available to clients that they can go and join and see if you can find the wild horses, which is quite an adventure. It's a beautiful part of the country, riding on the escarpment there, seeing nature and the beautiful views.
I've never heard of this thing called wild horses. So tell us a bit about them. And are they horses that must have been domesticated and escaped at some point in the past, or they never got domesticated, which is very interesting if that's the case?
Yeah, I think that the current lot of horses, both in Kaapse-Hoop as well as Rooisand down in the Cape Province, Western Cape Province, there's some speculation about how they came to be there, that they would have escaped from original settlers or after the South African War at the turn of the 19th century. Horses that were left behind or escaped some of the British or South African troops. So there's various theories, but they left, and there's organization that looks after them in the two particular areas, just to make sure that there's minimal intervention, but there is intervention from veterinary services also when absolutely necessary. But generally, they're left to their own device to breed and to get on with it.
So you began your journey as a psychologist being particularly interested in treatment resistance, right? Do you think there's something about equine therapy that helps with resistance, that breaks through resistance?
I think definitely there is, in the sense that that it presents the person with, as we said earlier, with the unknown, with the ill-defined, with the openness of the model, that they need to insert their solutions or their creativity. And I think that addresses that. It has the possibility to address that issue very, very succinctly.
Now, the equine therapy is part of a package where they're getting other kinds of treatments. They may have a CBT session, cognitive behavioral therapy, with a particular therapist, let's say, or group therapy. Yeah. So it's within a package thing, right? So
that's correct.
Most therapies outside of a rehab clinic, like White River Manor would be one therapist sitting with one patient once a week for 50 minutes, right? And that would be it. They wouldn't be seeing a whole gamut of other therapists, which is kind of what's happening at White River Manor, but that's for particular reasons to do with the fact it's an inpatient facility. And also there's an urgency to try to deliver change fast because people have been taken away from their lives and they don't want to sit around having therapy forever.
Yeah.
So would equine therapy work if it wasn't for the case, there's all these other therapies around it, alongside it? I mean, could it work just by itself? Because that's how most therapies work, right?
Yeah.
Over to you. What are your thoughts?
It definitely does. I have a number of colleagues that that I've met during the course of my studies, as well as just being an equine therapist myself, that are in independent practice or private practice, as we call it sometimes in South Africa. That together with maybe a referring psychologist with the equine therapist then sees the client together. So it can be, and it is offered as a standalone model as well, with good success.
So the British famously love animals. There's a famous saying that British love animals more than they like people. Do you think this is something that would work particularly well in Britain because of our cultural love of animals? I don't know what the situation is in South Africa in terms of the average South African's relationship with animals.
Well, I think it was Mark Twain who wrote that that the more I get to know people, the more I love my dog.
Right.
And I've at times had fleeting moments in my life where I think, the more I get to know this person, the more I love my horses. But enough said there. So yes, I do know that that equine therapy is already established in the UK from through the international organization that I did my studies with. I was joined in one of the courses that I did by colleagues that have come from the UK to participate in South Africa in the course presented here in South Africa. So I know that it is available there. I think if one does a search, you would be able to find some of that. And I think definitely, I think it's there's a universal appeal of the model for people to engage with. But I do think that particularly in the UK as well, it should go down well.
So we've only got about 4 minutes left. So this is normally the stage of the interview, because you've given us a lovely interview where I do this terrible thing. The gloves come off and I hit people with a very tough question.
Go for it.
So brace yourself. So many people would say, look, the reason why people don't get better is simple. You don't have to overcomplicate it. They're not willing to make the sacrifice we all have to make in order to achieve personal change. Okay, let's say the sacrifice is that you're going to have to give up drinking and hanging out with your drinking buddies and all the things that accrue from it. It's a sacrifice and you have to make it. And therapy overcomplicates it because it tries to cushion people too much from the sacrifice. It tries to disguise it. Ultimately, you can run around with horses as long as you like. You can't escape the sacrifice. And a lot of therapy is actually an escape. It's an avoidance of confrontation. They go to therapy. They chat about stuff. They can always say to everyone, I'm in therapy. They're not really moving forward. It's just a dance that they're doing, right? So do the sacrifice. And for millions of years, not millions, hundreds of thousands of years, there were no psychiatrists. People just got on with it. Okay, they're kind of like, you just need to get on with it model. Okay, so what are your thoughts? You're in danger of pandering to people who like to think they're doing something about themselves, but they're not really, because they're just avoiding the ultimate point about the sacrifice. And you're not telling them, listen, ultimately, you're going to have to make a sacrifice. You're cushioning the blow too much, because there is a blow coming. At the heart of psychiatry, and like the rest of medicine, you got to do something you don't want to do. And people will go all around the houses to avoid doing the thing they don't want to do. Okay, have I been horrible in making that point? What are your thoughts?
Not at all. I fully agree with you. And the way that I explain that concept to clients that I work with is I use two words: because and despite. And I tell them that if I have to summarize or explain my profession or what I do on a daily basis with just two words, it would be those two words: because and despite. So when you get to the clinic, in the initial sessions, there's a lot of because work. Why are you here? What's this happened? What has happened in your past? Why have you got these dysfunctional coping strategies or these dysfunctional beliefs, whatever the case may be? And then at some point, I'm going to stop you and say, right, what are you going to do about that? Despite that now. So living your life not because of everything that happened, but despite everything that happened, and because of that, you need to change. So that is what clients are confronted with in a constructive but very direct manner.
Okay, so at the heart of therapy, I mean, we're converging now. I think what therapists are bad at is inspiring people to make the sacrifice. And that way you put it beautifully. We move from because to despite is a beautiful way. And I think there's an artistic sense in which that's what therapy has. It's an artistic sense of the charismatic therapist has a feel for that, is how we inspire people to do the difficult thing. And therapy is actually usually quite bad at that because that's the mysterious X factor. It's difficult to train. What are your thoughts?
I agree, and it takes me back to a question that I had in my early years whilst I was still studying. One of my lecturers posed us a question and said, "So what do you believe psychology to be, a science or an art?" And the conclusion was that it's a science that needs to be applied very artfully.
Oh, very well put.
So,
lovely line on which to end. So we're run out of time. Gert Jansz van Rensburg, equine therapist. Thank you very much indeed for talking to us from White River Manor. Thank you very much indeed.
Thank you very much for the opportunity.